Good afternoon. My name is Kayla, and I will be your conference operator today. At this time, I would like to welcome everyone to the Diversity and Inclusion, Promoting Health Equity by Understanding Unconscious Bias webinar. After the speaker's remarks, if you would like to ask a question, simply press star then the number 1 on your telephone keypad. To withdraw your question, press the pound sign. Thank you. I would now like to hand the call over to Winifred Quinn. Please go ahead.
Great. Thank you, Kyla. And hi, everybody. Good afternoon or good morning, wherever you may be. And yes, welcome to Diversity and Inclusion, Promoting Health Equity by Understanding Unconscious Bias. What is unconscious bias and how does it influence nurses and others? Learn about the neuroscience behind unconscious bias and how these subtle beliefs and behaviors can have large impacts. Understand how nurses can recognize and handle unconscious bias at the individual, organizational, and institutional levels so as to minimize impact. I'm also not a nurse, so I hope to, as a nurse champion and as an everyday person, I also hope to learn the same. Participants will define unconscious bias and differentiate the types, explore the neuroscience of unconscious bias, discuss how unconscious bias affects health outcomes, and determine strategies for mitigating the impact of individual and institutional unconscious bias. Before we go any further, I do want to mention that we are recording today's webinar, so if you missed a section or would like to pass it on to colleagues, which we highly encourage you to do, you may find the recording on our website at www.campaignforaction.org/webinars. We will take questions over the phone at the end of the webinar. However, we also encourage you to type questions in the chat feature throughout the webinar. We will respond to those questions at the end of the webinar as well. If you choose to use the chat feature, please be sure to send your questions to quote-unquote everyone. So we have 4 fantastic people with us today. We have the Campaign for Action's co-chairs of our Diversity Steering Committee, Dr. Carmen Alvarez. Dr. Alvarez is an assistant professor in the Department of Community and Public Health at Johns Hopkins School of Nursing. And then we also have with us today Dr. Adriana Perez, who is one of the Campaign for Action's diversity consultants and is an assistant professor of nursing and a senior fellow at the Leonard Davis Institute of Health Economics at the University of Pennsylvania School of Nursing. And they will in turn introduce our featured speakers. Carmen and Adriana, please take it away.
Great. Thank you so much, Wynn. Yes, we are very lucky to have our 2 experts join us today. We have Ms. Minjon Tholen and Dr. Piri Ackerman-Barger. Ms. Tholen is a senior consultant at Cook-Ross and a diversity and inclusion strategist with almost 10 years of experience in advising leaders as well as leading and designing various programs. Ms. Tholen has also spoken at multiple conferences, including the United Nations Women's Empowerment Principles Annual Event and the European Network Against Racism Summit. So welcome, Ms. Tholen. And to start, may you please briefly tell us a little bit more about Cook-Ross and your work with your team?
Absolutely. Thank you, Carmen. Hi, everyone. My name is Minjon Tholen, and as Carmen mentioned, I am a consultant with Cook-Ross. We are an organizational development firm, and we specialize in diversity and inclusion and conscious leadership. And it's a pleasure to be here with you today.
Thank you. And now I will let my colleague, Adriana, introduce our other speaker, please.
Thank you, Carmen. Yes, I'm excited to introduce Dr. Piri Ackerman-Barger, an assistant clinical professor at the Betty Irene Moore School of Nursing and diversity consultant at the Center to Champion Nursing in America. So I'm excited to work with Piri. Her research relates to health equity and social justice, and she has a particular interest in the preparation of nurse leaders and nurse educators with the capability and desire to promote diversity in schools of nursing. She conducts research and serves as a national consultant and speaker on strategies to optimize student success for underserved and underrepresented groups in health professions. Piri?
Hi, Adriana. Thank you. So I introduced the learning objectives.
I can go ahead. This is Minjon. So I will begin this session, and Piri and I will alternate for today's presentation. So I'll go over the learning objectives with you, and what we're going to do is to start with defining unconscious bias to understand a little bit more about the neuroscience of this. Piri specifically will talk more about some of the phenomena related to unconscious bias, like microaggressions, and how it expresses itself in organizations and in the work that you do. She'll also talk about determining the health outcomes or how unconscious bias can impact the health outcomes and some of the different types of unconscious bias that we can identify. I will close us out with some strategies for mitigating bias personally, and also thinking about this in a broader way about how organizationally we can think about bias mitigation there as well. So overall, the goal is to drive some awareness and create awareness about this topic, because what we know is that when workshops and learning from medical professionals is something that's part of our everyday, and really understand some of the science and the research behind this and understand our own personal relationship to this, we know that it can drive some change. I always like to say that, the combination of awareness and intention is what tends to be a critical factor for behavior change. And so this is part of the awareness component. So let me start with a question here for you. And the question is, what are your associations with this topic? So you signed up for this session, and we're very glad to have you here. And, of course, the word unconscious bias or bias itself is one that we're familiar with and probably have some associations with. So in the chat box, please go ahead and type in the immediate associations that come to mind for you when you hear unconscious bias. And again, make sure that you send it to everyone so we all can see it. So go ahead and share with us your thoughts. What are your associations with bias? Great, Cheryl, you mentioned judgmentalism. So judgment, right, is part of the associations there that we hear. Thank you for sharing. What else comes to mind for you? And I can ask the question differently as well. When you think about bias, do we usually think of this as a positive or a negative thing? Negative. Aha, thank you, Stephanie. Prejudice, I see here, different cultures and the thought of as negative. Racism, so the foot and mouth, so awkward conversations or awkward situations, wonderful. And so what I hear in that is typically when we think about bias, we think about that as something bad and something that we're not supposed to have. However, the way that we approach unconscious bias is actually not as good or bad as it's in itself. In itself, we talk about bias as a neutral function of the mind, one that allows us to distinguish between one and another, and then to have a preference, right? So, of course, those biases then could have negative impacts, and we will certainly talk about that because the goal here is to understand bias and how it is critically important for us as human beings to have this, and to recognize when it might get in the way of the work that we are committing to do every day. So that's a little bit different perhaps than you might be used to, and it requires us to have an open mind because we tend to have a negative bias with the word bias, right? So let's define it a little further. We would say that bias is a tendency or inclination that results in judgments without question. And I see in some of the chats that you're sharing here things like preconceived notions, and that's exactly what it is. It's prejudgments, it's preconceived notions that we have created that allow us to have an automatic response to something and to have like a shortcut, right, to help us navigate the world. So some of these biases we are aware of, and we know that we have them. They're more conscious biases for us. Now, what we're talking about specifically today are those biases that we're unconscious about, which is actually the majority of our biases. And so we talk about unconscious bias specifically as those types of mental associations that happen all the time, but then without awareness, intention, or control. For example, when you just heard the various voices of the people that introduced us at the beginning, or when you hear my voice, you may have immediate associations with that voice, right? You might think it's either warm or cold, or it sounds knowledgeable or not. So we have all kinds of associations very quickly that we're just not aware of, right? And the reason why it's so important for us to explore that is what we also know is that those biases could often conflict directly with what we're consciously committed to. But because I think it would be fair for all of us to say that we're consciously very committed to making objective decisions, to treating people equitably and fairly, to have an open mind, all of these things, most of us would strive for that. And we're also human beings who have this function of bias in our brains, right, that we can become more aware of. So in other words, exploring this topic can help us to align our decisions, our behaviors, our interactions with our intentions. It's hard to take responsibility for things we're not aware of, right? So let's try to bring this to a level of awareness. Now, why do we have bias? Why do we need it? Bias is a survival mechanism, right? It helps us to very quickly distinguish between safety and danger, friend or foe. I had to know who was safe to me, right? And typically people who are safe to me, right, to all of us, are people that we're comfortable with, right? In the workplace and interactions with colleagues or with patients. We're not so much talking about a life or death situation, although, of course, in healthcare, those situations in the workplace happen. But when it comes to interpersonal relationships, we're usually really talking about safety as a sense of comfort with certain people. And who are we comfortable with, right? We tend to be comfortable with people that we're familiar with. So safety becomes comfort, and comfort is familiarity, and we're familiar with people that are like us, that think like us, act like us, look like us, all these different things that make us similar. And you can see that automatic tendency that we have to do that could get in the way of diversity and inclusion, of cultural competency, responsiveness, all of these different things that happen in interpersonal interactions. So the goal for today is to understand bias as a critical survival mechanism that's as natural to us as breathing, and that could have also a very significant impact in how we react and relate to people. And these biases come from somewhere, right? The function of bias in itself is hardwired for us. You can think of it as the hardware, but it works with software, and that software is what we would refer to as our background. Our upbringing, our experiences, our cultures, the people around us, our media, our societal messaging, our politics, everything that we encounter as human beings creates this background for us that helps to understand the world in a certain way. It provides glasses, if you will. It's like a lens through which we look at the world. And we all have our unique way of doing exactly that, right? And that unique viewpoint also brings its biases with it. So all of us have our own set of biases that we operate on, and we are usually not aware of the fact that that's happening. It's just the way we see the world. So peeling that apart a little bit can help us to start becoming aware of that more. And what I'd like to do now is to give you an example of how our biases in our brains could work, right, and how this shows up. So I'm going to need your participation. All right, so if I can ask all of you to make sure you're looking at the screen, and if you can, if you're alone in an office and you can speak out loud, please call out loud the colors of the letters that you see on the screen, okay? If you can't say it out loud because you're surrounded by other people, feel free to just think it in your head, but really consciously read the letters that you see here on the screen, okay? So let's go ahead. Okay, so again, what colors of the letters do you see here? Okay. So how is that for you? Pretty easy, right? I'm assuming you all know your colors, so this should be fairly straightforward. But now let's do this again. Okay, the same thing, the color of the letters. And again, I'm going to ask you to call it out loud if you can, or to just try to say the colors in your head. All right, let's do this again. Okay, so keep trying. I know this is a little bit different. Okay, great. So I think it's probably safe to assume that the second time around, it was a little bit more difficult to do this, right? Because now there was a discrepancy between the color of the letters and the letters, or the color that the letters spelled out. So here is what just happened. You probably noticed a little bit of a tug and pull in your head, right? And because there's two parts of the brain here that are a little bit in conflict with each other. And this is not a brain science class, and I'm sure some of you know the science of our brains much better than I do. But just to give you an explanation of what just happened, is that the two parts of the brain that were in conflict is what we call our fast brain and our slow brain. And this is language borrowed from Daniel Kahneman, who wrote a book called Thinking Fast and Slow, a great read if you're interested in things like this. So the fast brain is a part of the brain we call the survival brain. It's our reptilian brain, the part of the brain where fight or flight lives, that safety or danger, friend or foe dynamic I mentioned earlier. It's also where our shortcuts live and our autopilots, right, things that we don't really have to think about. The other part of the brain is what we call our slow brain, and this is the part of the brain where we can actually think about our own thinking, where we can be self-reflective. So you can think of our fast brain as reactive and our slow brain as reflective. We know that as human beings, all the information that comes our way is first processed in our fast brain, and then some things make it to the slow brain, and we bring it to a level of consciousness. But, like, for example, right, if you have a reaction to a colleague because they disagree with you on something, you might have an emotional reaction, which is a fast brain reaction usually. But then what could happen is that you think about it and say, why did I react that way? Wow, that was really maybe a little bit of an overreaction there. Now you're thinking about your own thinking. You're self-reflecting, right? What we know is that it takes our brain more energy to use the slow brain. It takes us about 20% more glucose to do that. So when we're busy, tired, distracted, stressed, emotional, we tend to rely on our fast brain because those shortcuts cost our brain less energy. And we are in fast brain all the time. In most organizational environments, because of the fast pace, that's just the reality. Now, particularly in healthcare institutions and when you're working with patients, the stress could even be worse, right? When there is a code blue or there's an emotional reaction from a family or someone passed away or other difficult things or emergency things, that could be a real impact of that. And we might be relying on those shortcuts a lot more, which means that our biases could influence a lot more at that moment. So I'd like you to take a moment now to think about this. Where are you reactive? Where do you use your fast brain? And where might it serve you to slow down? So go ahead again in the chat. Please type in and share with us any fast brain reactions and where it could help to slow down. And specifically think about what are some of the circumstances that you might encounter in your responsibilities where it's more likely that you'll use your fast brain. When we're tired, thank you, Piri. Absolutely. At the end of a 12-hour shift, of course, when you're just exhausted at that point, it's so much more likely that you're going to rely on your fast brain, right? And that's something you're probably aware of, but what we know is that can also mean that we're then really making a lot of assumptions and are missing some really critical things. When you're in unfamiliar surroundings, absolutely, because a lack of familiarity, right, tends to translate to us like the unknown. It translates to us as a potential danger. So we're in our fast brain, absolutely. When you have to make multiple decisions at one time, absolutely, that's when your brain is frantically trying to figure out what to do, and that's where we use our fast brain. Or a high volume of patients that come your way, and it puts a stress on the system. I see here emergencies, right? Real stressful moments, whether that's for you, whether it's for the patient, or with your colleagues. There's that can create, you're kind of going in autopilot there. You've been trained to do this, right? When you're driving, yeah, that can happen. Paula said that. When you're driving, the automatic driving here can certainly be with our fast brain. It's a little bit scary, right? We might not realize we're behind the wheel until we're parked at our destination, which makes us efficient drivers, but also means that we're probably pretty absent-minded. So thank you for some of these examples, because we can probably all relate to this, both in our personal lives and in our professional lives, that we use our fast brain and we're very reactive, right? So that is one of the things to keep an eye out for yourselves, is to notice those moments when you're in those situations, to really try to slow down a little bit as much as you can. One of the things that we know is that it takes about 90 seconds for our amygdala in our fast brain to relax enough so that we can observe it with our slow brain. So you know how people say count to 10? Right? It's actually count to 90 when you're upset, because that allows you to quiet it down enough. So if you can take 2 more minutes in some situations to kind of really observe yourself, it could help you. Now, recognizing that that's not always possible, right? So in emergencies, you may not always be able to do that. But just to be aware that our biases might guide us more than we think. And so just to summarize this for now, and then I'll hand it over to Piri, but we talked a little bit about how our background shapes the way that we see the world, right? And how our biases are a result of that. And those biases, if we don't pay attention to them, they could govern us all the time. And they may not show up in our behavior, but when they do, it's usually in what we call micro-behaviors or microaggressions, small ways that give advantages to some and disadvantages to others, and over time can create real disparities. And that, of course, is what we all want to avoid. So Piri will talk more about how all of this can show up in your day-to-day.
Thank you so much, Minjon. That was really wonderful. I've been taking notes and really enjoyed that. So one of the things that I want to go into is really having an understanding of how unconscious bias can be problematic when we're in the clinical setting. And so if we think of unconscious bias as the processes that are happening in the brain, some of our beliefs, whether we're aware of them or not, we can then think of the micro-behaviors or microaggressions as some of the outputs of unconscious bias. And I have a definition here for you. Microaggressions are the brief and commonplace daily or verbal behavioral and environmental dignities that, whether intentional or unintentional, that communicate hostile, derogatory, or negative racial, gender, sexual orientation, religious slights, and insults to the target person or group. So those are those sorts of exchanges where you leave the exchange, like if you've received a microaggression, you leave the exchange wondering, what just happened? What did they mean by that? How do I respond to that? And that process in itself can take a lot of energy from the person that's experiencing the microaggression. And so there are many types of microaggressions, but I've listed here some examples of the kinds of microaggressions that exist. One is the idea of ascription of intelligence based on race and gender. And this is the assumption that maybe when people of color are hired or admitted into schools, it's because of affirmative action rather than their qualifications. Alien in one's own land. This is an experience that Asian American and Latino Americans experience where they're assumed to be foreign born. Heteronormative language. This is that assumption usually that heterosexual and cisgendered people have, where they assume that individuals in opposite sex relationships. And then color blindness is, when you hear people say, I don't see color, or another one might be, I don't think of you as being Black or being Mexican. And these can be hurtful, and as you can tell, they're somewhat subtle, and they feel intangible, and part of that is what causes the distress, is that you have to figure out what was meant in that moment. There are also microaggressions that have been subsumed into the healthcare culture, which I often find concerning, but fairly commonplace. So one of those is something that's said to overweight and obese patients. If you just worked a little harder to change your lifestyle, you wouldn't be in the hospital, right? And, oftentimes there's a whole context around why somebody is in the hospital and how they got there that day. Also, we do this to people who are in pain. We might say something to them like, "You're not in that much pain. This is drug-seeking behavior." Another one that nurses hear often, "You're so smart. Why didn't you become a doctor?" Right? This is something that one of my Latino students said to me, who was working on a unit and doing a really good job. And somebody on the unit said, "You're a credit to your race." And, that may sound like a compliment because he's a credit to his race, but what is that saying about his race, right? So that was distressful for him. And a nursing student recounted to me an interaction she had with a white student when she got an A in one of the few A's in the classes, and they said, "You only got an A because they need to fill a quota." So all of these things can be very hurtful. And so from the patient perspective, if you feel like you might be entering the healthcare system and that you are going to experience discrimination or microaggression or have people judging you based on their either explicit or unconscious biases, you might be less likely to want to enter the healthcare system. It means that you may not choose to have preventative care. You may wait longer into your illness before you decide to come into the healthcare system. And we know that related to that, the healthcare outcomes are poorer for those folks. So just a moment talking about how unconscious bias can lead to health disparities. And so I have 4 examples for you from the research. And so one of them is that Black patients are less likely to receive analgesia than white patients. And this has been studied in ERs and in clinics and things like that. And there's a newer study that came out that showed that this wasn't just true for adults, that Black children were also less likely to receive analgesia than white children. Hispanics are 7 times less likely to receive analgesia than non-Hispanic patients. So it's people of color, not just Black patients. Black patients are less likely to receive treatment for acute coronary syndrome. And this also happens along gender lines. There's a research article that said that women are less likely than men to get knee surgery, even when it's clinically appropriate. So we can see that there can be problems with our unconscious biases, that these sometimes play out. And like Minjon was saying, we are often tired and stressed out in our healthcare settings. And this may not be in alignment with what our value systems are. And that's what becomes problematic, is that oftentimes we're not doing it intentionally or even with our knowledge. But there is opportunity for us to become, acknowledge it and to become more aware. So in that vein, I would like to spend a little bit of time talking to you about how unconscious bias manifests. One of the types is called selection attention. And by the way, these definitions are all provided by Howard Ross, who is one of the partners in Cook-Ross. This is from his book, and I've used nursing examples to exemplify them. So selection attention is a mental process through which we selectively see some things but not others. So when we as healthcare providers are skeptical that health disparities exist among racial groups, this is usually selective attention. The scientific data is robust, and we see patients every day who tell us and who show us outward signs of disparate health. Yet we're often able to convince ourselves that this is not true. We select what information to retain and what to discard, and we tend to discard information that complicates our individual views of the world. So an example of selection bias is this slide right here. So this is a radiological slide, and radiologists are highly trained to recognize things like tumors and pleural effusions and things like that. So a study was done, and there were many radiologists that looked at this image. And if you notice in this image, there's actually a gorilla right there in the radiograph. And so 83% of the radiologists who were asked to look at this didn't notice that gorilla right there on the image. And, so the positive side is that we become highly trained, and that's part of what makes radiologists so good at what they do, is they have selected to see certain things. But the downside of that is that then we sometimes become blinded to things that are right in front of us, and that can be problematic. We can miss really important cues from that. Another type of unconscious bias is the propensity to label people, ideas, or things based on our initial opinions or first impressions. An example I have of that is a physician that I used to work with, and he told me once that it's hard to be polite all of the time when your spine is disintegrating. He had a disintegrating spine and was in pain all the time. And he looked older than he was, and he had a gruff demeanor. One day I was working with him in the emergency room, and a well-meaning elderly patient gave me a $5 bill and pointed to this doctor and asked me to give it to the poor homeless man. And so she had made a diagnosis based on what she thought of him and thought that he might be homeless. So that's an example of diagnosis bias. And we do that all the time when we see patients coming in, often not at their best. We diagnose who we think they are based on our first impression. Another kind of unconscious bias is called pattern recognition. So this is the tendency to sort and identify information based on experience or habit. So this is a pretty common tendency among healthcare providers. If you've seen one drug seeker, you've seen them all. And we tend to remember the patient who complained of back pain and was treated generously with opioids, only to find out that they didn't really have back pain but was addicted to painkillers. So now every time we see someone who complains of back pain, we think we recognize a pattern, and we're determined not to be tricked again. However, we're not always correct in pattern recognition, and when we are wrong, we risk undertreating patients who are indeed experiencing excruciating pain. And again, going back to that data that indicates that this happens more frequently with Black patients than white patients, even among children. So the next type of unconscious bias is the idea of value attribution. So this is the inclination to imbue a person or thing with certain qualities based on our initial perceived value. And again, going back into the clinical setting, I've had the experience multiple times as a nurse where I provide patient education about a procedure or something that's going to happen, and they look at me with skepticism, and, the jury's still out on what information I've given them. But then when the physician comes and tells them the exact same thing, they believe it and are like, oh, yay, thank you for that information. And, I get the sense that there's a perception that the information provided by a physician is more credible and therefore more valuable than what's provided by a nurse. And that would be an example of value attribution. The next type of unconscious bias is the idea of confirmation bias. So this is a tendency to gather information or respond to a circumstance in a way that confirms an already established belief or idea. So we tend to like to be right, and we look for outward confirmation that we're right. And, one of the scenarios that I was thinking about is related to sexual assault of women in the U.S., and the rates are unacceptably high. However, when we hear court cases about sexual assault, the perpetrator often says something like, she wanted it, or she said no, but she meant yes. And I wonder if confirmation bias, could it be at play? Could it be that the perpetrator wants this to be true, and despite rebukes and statements of no, they're only gathering and retaining the information that confirms their belief that the woman is into them. So concepts like she only said no once or she didn't fight back becomes confirmation in the perpetrator's mind that it's okay to continue. And I know that this example may seem extreme, but I really wanted to illustrate that biases can be more than just social faux pas, but they can be dangerous and life-threatening. One of the other types of unconscious bias is the idea of commitment confirmation. So our minds often become attached to particular points of view, even when they are wrong, and they can lead to a form of confidence bias that is self-motivating. So, this, again, it happens when we have overwhelming data that indicates that health disparities exist, based on race and gender. But healthcare providers overwhelmingly deny that they as individuals may have unconscious bias that perpetuates health disparities. We always think it's somebody down the road, not us. We would never do that. There's also anchoring bias. So this is the tendency to rely too heavily on one trait or piece of information when making decisions. And I think about the experience that transgender patients often have when they come in, that people are so focused on their trans status that they're not looking at the diagnosis. So we've had trans people say that they come in for a common cold or a respiratory issue, and during the course of treatment, they get a genital check. And so for folks that are cisgendered, that doesn't happen. People listen to your lungs, they might look in your throat, but we generally don't get a pelvic exam when we're going in for a respiratory issue. So why is it that trans people are experiencing a genital exam during this? And it's very likely that it's anchoring bias, that people are so focused on their trans status that they're missing, many of the other parts of somebody's identity and presentation. So the last type I wanted to talk about is this concept of groupthink. So when we're in meetings and when we're working with others, we often like it when everyone agrees and comes to the same solution quickly, because then we can move on to the next thing and get things done. However, this makes us less likely to notice our blind spots or to think of innovative solutions. So with these different examples of unconscious bias and understanding how it might manifest, I'd like to hand it back over to Minjon Tholen so that she can help us figure out ways to mitigate our unconscious bias and how to start that rewiring process. So Minjon, it's back to you.
Great. Thank you, Piri. And I think that was such a great overview of the many different biases that could show up. And what's helpful sometimes is have these terms in mind that you can spot it, right, when it's happening, and you can have a name for it and understand what's going on. And so what I'd like to share with you now is to think about a very simple model, a quick model that we call our pause model, that helps us to think about our reactions and really to have a slow brain process here to mitigate our biases. And I just want to be very clear that this is not some magic pill, right? This is not going to all of a sudden make us be able to do that. It's an ongoing practice. But just a few things to keep in mind here. Because what happens with bias, right, is that when we're encountered with something and we have an interpretation of that something, and that then is our bias there that then shows up. So this is an opportunity to distinguish between what's happening and what we're making up about it. So the first step, this is an acronym, the first step is pay attention to what's actually happening beneath the judgments and assessments. So what we mean by that is really what's objectively there. What is the data that I'm working with? And then what is my reaction or interpretation or judgment about that? So let me give you an example. You are meeting with a patient who does not make any eye contact, right? So what's happening is, well, let me first say, you may have a reaction to that. When I mentioned that, you may immediately have an emotional reaction to that, because eye contact is one of those things that we've learned in our background, at least for most of us in sort of Western, North America, Western Europe. Making eye contact is a sign of respect, right? It's a sign of I'm listening, I'm paying attention. But that's not true in all cultures, but that's usually what we look for. So when someone does not make eye contact, We might think that they're shy. We might think that they're not listening, that they're not understanding, that they're not engaged. So that could be the interpretation, but what's really just happening when we think about the objectively observable behaviors is that someone is not making eye contact without any judgment, right? Now, we have an emotion about that. But the next step here is to think about, well, what else could be possible besides my own interpretation? And what else could be possible, what other reactions there could be? It could be, for example, that this is someone who maybe they are shy, or maybe they've learned in their culture and their upbringing that people who we consider authorities, which very often we are taught that physicians particularly, but nurses as well and other providers, that they are authority figures, right? So when we're faced with someone, we could divert our eyes, I should say, and feel like, we should not be looking them in their eyes. So in other words, what happened is no eye contact. My interpretation is all kinds of interpretations could be there. And now I've distinguished between data and interpretation. I could see that there could be other things besides my interpretation that could be true. When we know that, now it's time to think about, what is my action plan here? What could I do? What is a productive way to deal with this recognition that I have a reaction to something? And you can imagine what I'm sharing with you here, that this is a slow brain process, right? Because our emotional interpretation and reaction lives in our fast brain, and now we're thinking about that reaction. We're analyzing it. So that requires slow brain activity, like really reflective thinking. So what could be an empowering way to deal with this could be to you may decide, okay, I get that there might be other reasons. They might totally be paying attention. Let me just try to set aside this immediate reaction and really provide the care that I can and communicate as best as I can. It could be that you ask a question and say, I notice that we're not making eye contact. Is that your preference? Is there something that gets in the way of our conversation? One of the things that we tend to be afraid of, right, is to ask questions. And there's an art to asking questions. And especially in healthcare, of course, trust is critical to the patient-provider relationship. And so how we ask questions and how we react is critical. So the last step is then to actually execute your action plan, right? And once we've thought through how can I now deal with this, and then actually do it. But really this model is meant to help us distinguish between observable data, what I'm making up about the data, and now that I recognize it's an interpretation, what do I do with that, right? And so it's a simple model, but it's a way to get us from our fast brain to our slow brain. And if you could walk through this a few times a day, of course not in every situation, but just for a few minutes, what you start to notice is it's like a muscle to practice, right? It's that the more that we try to think about our own thinking, the more that we are able to very quickly notice a reaction. As opposed to being reactive, we can now analyze our reactions. So this is just one of the models to think about, and given our short time, I'll leave it at this, but certainly if you have any questions about that, we can address them in just a moment. But shifting now from the personal to the larger context, because what we know, of course, is that training in itself is important. Learning reinforcement is important. But it's not the whole picture. So one of the things with unconscious bias work is just going through the session today. I hope that you're getting some really valuable terms out of this, some interesting insights into yourself, into this topic. But it requires ongoing learning and ongoing challenging of ourselves. So some of the best practices in thinking about this in the institutional level is to really think about integrating awareness of unconscious bias in other learning. For example, if you have any work on patient-centered care or other like cultural responsiveness or other ways in which you're training people in the organization, integrating concepts of unconscious bias in it, finding ways to continue the learning in different formats, it's really, really critical. Now, connected to that is what we call priming. And this is something else that we work with organizations around, is priming really means constantly reminding ourselves that this exists and committing to acknowledging them and working through them. And so you can prime people by just mentioning it. For example, I was working with a senior group of leaders of an organization yesterday, and we talked about how could you, at the beginning of, for example, a huddle or a staff meeting, just kind of say, hey, you know, as we're talking about this particular patient or project or situation, there may be some biases that come up, right? There might be some automatic assumptions that we're making, but let's be mindful of that as we go through our conversation today. Or, you know, integrating short videos or other documents into a process to kick off a particular group process, for example. It helps us to manage our own biases as well as that groupthink that Piri was talking about, to challenge that a little bit. So priming is just what are the reminders that we can integrate into other systems and processes and practices and into our day-to-day that can help. If you're someone who's coaching others, reminding people of bias or coaching them about that could also be really helpful. And what I mean by that, just really briefly, is you may not want to say bias as a word, right? Not everyone has a really comfortable relationship with the word bias. But you could say, do you think you may have made any assumptions here? Or was there anything that we were missing, right, in terms of selective attention? Was there any signs that we missed in this situation? Did we jump to any conclusions about what the condition was of this particular person? So even though you never say the word bias, you kind of continue to remind people of the fact that it exists. And so that's what we would call priming. And you can do that in a host of different ways, like I said, with resources or just in how you talk about this. Now, that also brings us to systems and structures. Bias lives in our organizations. It's not just in human beings. It lives in our processes, in our guidelines, in our policies, in our communications, in our talent management structures, in protocols, even in questionnaires that we might use for like intake questionnaires with patients. So we know that bias is built into everything in the organization, and we're not aware of that. Right? It's just the way the organization functions. And so another best practices around mitigating bias in institutions, it is to analyze it and assess where it might live at a structural level and to address that as well, so that individuals committing to changing their behavior can work in tandem with an organization really reflecting on themselves and using a slow brain approach to identify where it might live in the organization as a whole. And that then finally can help us to build in some accountability to this, right? There's individual accountability around bias, but it's also from a leadership perspective or from an organizational perspective. There's ways to measure some of this. For example, one of my clients measures the work that's being done around unconscious bias as partly within patient satisfaction surveys, for example, right? Or other, when it comes to talent management, it might be part of performance reviews for hiring managers or leaders. So accountability is another important piece to help us really get granular about how do we mitigate bias in that way. So in other words, today we talked about personal biases and how those show up, and this is where we need to start, right? Because we also know that life is kind of like a tennis match, right? We can only control what is on this side of the net, and that means that our own awareness, our own self-reflection, it is always the starting point. And then there is a larger organizational context that we could also consider. So for now, I'm going to wrap up my section, and we can move on to questions. And so questions can be shared via the chat, but there might also be questions already that have come in. So we look forward to hearing from you.
Great. Thank you so much, Minjon. This is Winifred Quinn again. And Minjon and Piri, thank you very much for that very informative webinar. Lots of new concepts for the Campaign for Action that are new to our audience. So thank you. And at this point, Kayla, I would like to open the lines for any questions, and I also encourage people to type your questions into the chat box if you would prefer to do that.
Thank you. Ladies and gentlemen, at this time, to ask a question, please press star, then the number 1 on your telephone keypad. Again, that's star 1 to ask an audio question. We'll pause for just a moment to compile the Q&A roster. There are no audio questions at this time.
Okay. So Melissa Ware has asked the question about the slide deck being available. We posted to the campaignforaction.org/webinars within a couple of days, a couple of work days of the webinar, so at the very latest Monday. Yeah. So, or a week. A week. Madeline is indicating that it's a week. Okay, so that's where people can find them. And will we also have the summary?
Yes.
Okay, and we'll also have a written summary so that, and it's not, they're normally about 5 pages so that it's a quicker read just in case people don't have an entire hour to go through them.
When this is Adrienne, I have a, oh, sorry. Thank you. Thank you for that. I have a question for our speakers, for Piri and Minjon. I wondered if in the work that you've done in your research, have you come across any programs or strategies, interventions, especially in the clinical setting, that nurses can use to respond to any kind of bias when they are, when they feel like the ones that are on the receiving end? I think about that because several years ago when I was working in the hospital, nurses came up with a really great tool that could help nurses respond to, at that time it was lateral violence or nurse bullying, and I wondered if you have come across anything like that.
This is Minjon, and here, if it's okay, I'll give you my thoughts on that. We have, and I think what the points you're bringing up is that it's really critical, right? Is that our biases, we have our own biases, which people always have biases about us, and of course, in a clinical setting, that happens a lot, especially because a lot of people are under stress in those settings, and their emotions are involved, and all these different things. Those biases can be heightened, and what happens then is that the patient-provider relationship is basically one where we're reacting to each other's biases constantly. And so we actually work with a lot of healthcare organizations around managing biases from both sides as a provider and as and as someone who might be at the receiving end of it. So there are certain ways to talk about that, but I would say that the model that we would recommend here actually is pause as well, but then from the other side, right? It's like, I'm noticing there's a bias. Is that, let me observe the behaviors, let me understand what's really going on here. That's one of the models. There's other things to consider, and Piri might have more thoughts on this, but certainly there's a lot of work that we do, and I'm sure many other great organizations are doing around that.
Yeah, very helpful. Thank you, Minjon.
I agree that this is something that's really hard to navigate when you're in the moment and you're on the receiving end of unconscious bias or a microaggression. One thing I like to do for folks is, one, validate that it is happening. Like there's actually a name for this. This does happen to you sometimes, and then acknowledging how hard it is to be in that moment, deciding what to do. And that I think a lot of people feel torn between, should I have said something, or was it okay to not say something and focus on my safety, and that both of those options are valid, rational, and reasonable. So there's that aspect of it. I also think it's important to focus on, the people that are perpetrating, and we talked about that before, microaggressions. And I think it's disturbing for people that realize, yes, I've been on the receiving end, but it's extremely likely that I've been the one that has committed the microaggression. And so how do we begin to mitigate that? A lot of it is recognizing your unconscious bias and actively moving towards those sorts of situations and groups of people that might make you feel uncomfortable, like, actively learn more about maybe the transgender community, And one of the ways that you can do that is by reading literature written by trans people. Janet Mock is an example. She tells you what it has been like to transition from male to female. And, and then engaging in more interactions. And then the other thing is, what do you do when you've witnessed somebody else giving a microaggression and receiving a microaggression? Do you have any obligation as the bystander? And again, you have to make a judgment call. But is there a way, and Minjon said this beautifully, rather than saying, I think that you just made a microaggression or that you have unconscious bias, but what assumptions were there, or what did you mean by that, or help me clarify that statement so that what happened is being acknowledged, but the burden doesn't always land on the person that received the microaggression or the unconscious bias.
So this is Winifred, and I am so grateful to the points you just made, Piri, especially for, I am from the predominant white community, and I myself have recognized from time to time, and probably more often from time to time, how my unconscious bias is active and how it's impacting myself and others around me. And one of the ways that I try to address that is continue to recognize it, acknowledge it, forgive myself, and improve. And that's what I hope others in power dynamic situations who are experiencing unconscious bias can do for themselves as well.
And this is Minjon. I think what you were saying is really important, is that, to have some empathy for ourselves, right? That we are human, and this is human. Now, that doesn't mean that we can just let it happen. We're still responsible and accountable for our behaviors. But the reason why we talk about unconscious bias is because it's something that we have in common. I do a lot of this work globally in any kind of, country, organization, and unconscious bias is something that we all can relate to because that's who we are. And so if we can have conversations with each other and with ourselves and have some empathy for ourselves, but still want to hold ourselves accountable, that's a very good place to start. And then it's about how do you then broaden that. But we always like to say that you can't take people where you haven't gone yourself. So it does start with ourselves when it comes to managing unconscious biases.
Okay, terrific. So listen, it's at the top of the hour. Are there any last and any other pressing statements that anyone would like to share before we end? Okay. Once again, my heartfelt gratitude to Minjon and Piri for organizing this and leading us in this work. Piri, it's such a benefit for the Campaign for Action to have you work with us now. I'm so grateful. And Minjon, we might be in touch for future work with you if you're interested. And to all, we are very grateful for your participation in this webinar. I see a lot of new names on here, and I encourage you to visit our campaignforaction.org website to find out what other resources we have, and if you are interested in participating on your state-based action coalition, please reach out to me for that. That would be awesome. So in the meantime, please register for our campaign updates by going to the campaignforaction.org/newsletter sign up. On that campaignforaction.org, at the bottom of the page, there are options for you to get engaged, and getting our updates is one. Finding out specifically about our webinars is another. And I believe there's also a general listserv that you could join. So please, again, I encourage you all to do that. Please also join us on Facebook and Twitter. That's where you would also find our webinars on the campaignforaction.org website. So with that, I would like to say it's a wrap.
Thank you, everyone. Thank you, Lynn.
Thanks, Carmen.
Ladies and gentlemen, that does conclude today's conference call. You may now disconnect.